is finger guided hemorrhoidal artery ligation with laser hemorrhoidoplasty. So what is a hybrid procedure? It's a big question in everybody's mind. So it's a synergistic combination of two or more techniques to enhance its efficiency. So first step will be FGHAL and second step is going to be the laser hemorrhoidoplasty. So why we should do it? Well, let us revise the anatomy. We know anal cushions, it has got a vascular component that is comprised of CCR, that is corpus cavernosus recti. But all the branches of superior hemorrhoidal artery, whether they are submucosal, intramural, extramural or transmural, they participate in formation of CCRs. But once we are ligating only the submucosal branches. So all other branches which help in formation of CCRs are taken care of by LHP, that is laser hemorrhoidoplasty. Non-vascular component, we know sliding anal cushion theory of Thompson. Everybody has read that paper of 1975. So we know once the CM ratio, that is connective tissue to the muscle ratio, is altered, there is sliding of the anal cushions. Then what laser hemorrhoidoplasty does? It leads to fibrosis and pushes the cushions back into the normal position. Patient selection. The most important is indications. Grade 2 to grade 4 hemorrhoids. I will show you a video how to do in grade 4. And contraindications, strangulated hemorrhoids. Absolute contraindication. Preoperative protocol, blood thinners to be discontinued. Valve preparation, we prefer to use bisacodyl 2 tablets 1 night prior. No enemas to be given in the morning. We find the field is very messy. And cefuroxime half an hour before surgery. You can choose any anesthesia of your choice, whether it's a general or even pudendal nerve block, or it is a spinal. Position, lithotomy or jackknife. And procedure protocol, now this is something very, very important. The point of entry should be the mucocutaneous junction. Type of fiber, Nitish has already told you, it can be conical or it may be a bare fiber. Pulse mode and dosage at the time of insertion, 6 watts for 1 second. And at the time of coagulation, it should be 6 watts, 3-second pulse. Dr. Mittal just said, please do not use 12 watts. It gives a lot of energy followed by a lot of edema. And keep on withdrawing fibers every half a centimeter, because in one go, the area covered is approximately 4 millimeters. And total joules, please do not exceed more than 200. Even if it's grade 4, you can give fan-shape energy, but please do not exceed 200 joules. Now this is a video to show you how to do grade 4 hemorrhoids, because once you know grade 4, grade 2 and 3 are very easy to manage. So this is a preoperative image. Now that is a Park's manual. You roll up 3 gauze pieces and insert them gradually, bring them out, and that is a prolapse you see outside. You can make out a lot of edema. Hyaluronidase is an injection which can be used. It's a standard common teaching. You use in the submucosal tissue. It is available in powder form. So you make 1 ml will be around 1500 international units. 3 to 4 ml can be injected. And in few seconds you will see everything has gone inside. So after that, palpate the vessels, and these are important landmarks. Take a figure of 8 stitch and ask your assistant to go for milking, because that is lead to disengorgement. After that, you tie the knot. Then keep on rotating the proctoscope and keep on ligating all the branches. Ideally, you should be able to ligate somewhere between 4 to 6 branches. And all these branches are to be ligated, otherwise chances of formation of accessory hemorrhoids, they are very, very high. And once you have done, again rotate the proctoscope to make sure all the branches have been ligated. So that is regression. And then come to laser hemorrhoidoplasty. The point of entry is a mucocutaneous junction. It's the white line of Wilton basically. So this is too light, is too bright or dull. You have to be very sure. And once you are inside, keep on rotating. That is very important. Otherwise, the tissue will get stuck at the tip of the laser fiber. So that is the way you can do it. And skin tags can be excised. You can use a cautery or you can use a bare fiber. Dr. Pradeep has already told you about that. And that's the ice finger. See, I am using a barrier. It is very important. Never use ice directly on the mucosa. It is a very important take home message. Because once you use an ice which is coming directly from the refrigerator, just see there is a crystallization always at the top. And in case you insert that very ice cube inside the mucosa, and if the temperature falls below -2, it can lead to crystallization. So that is very important to have a barrier, and I will come to, once we come to some other talk, I will explain to you about that. So once you have done HYLAS, you have given FGHAL, you have done LHP, still some part is left, the part of the mucosa. What you can go for? You can go for rectal repair or Blaisdell or FGHAL. Basically, Blaisdell and FGHAL, they are the similar procedures. So a very short video to show you how this procedure should be done. So this is the pre-operative image, that's the post-operative image after HYLAS, FGHAL and laser rhinoplasty. Now you take 3 interrupted sutures, taking mucosa, some mucosa and the fibers of the internal anal sphincter. Ask your assistant to push the piles inside the anal canal and take a stitch. So that is another stitch. Now always remember to stay half a centimeter above the dentate line. Otherwise, post-operative, the patient is going to have pain. So that is the way you should be doing it. So I will move on to the next. So complications. Now detailed lecture on complications I will be having after 2-3 talks. Vascular, that is pain, is definitely 2 to 3. And edema, burning and itching, hemorrhage. Now hemorrhage is something which is very, very important. I can quote a very small example how things can go bad. Myself and Dr. Pradeep, both of us were at Guwahati. We were just about to start dinner at 10 o'clock and suddenly I got a call from a hospital. So the patient is bleeding profusely. And that was on 25th day. So I asked my staff to call another surgeon. He came, he did little bit this thing, there was a bleeding from mucosal sloughing. So the diathermy he did at that time and the patient's life was saved. But I would have liked to do something else. Abscess formation, thrombosis and skin tags. Now Dr. Mittal wanted me to just compare all the techniques head to head. Now I will just compare Milligan-Morgan with, which is a gold standard, with FGHAL. You can make out the pain score is much less as compared to Milligan-Morgan. And recurrence, so again comparing with conventional hemorrhoidectomy, so recurrence with FGHAL is 1.28%. Now this is my data, absolutely authenticated, and we are going to go for publication. Already it is in publication. Let us see when it is published. And this is the first landmark publication which was written by me, Dr. Niranjan Agarwal and Dr. Kushal Mittal. So that was a 346 patient data. First publication in the world ever mentioned written on FGHAL with laser rhinoplasty way back in 2019. And long-term outcomes, that is a current study which has gone for publication, 703 patients for 5 years, and the overall success rate is 98.44. And the places where we have failed is only grade 4 hemorrhoids. And this is something already what the word says and what we say, the results are almost similar. There is not much change in that. And advantages, minimal pain, less tissue trauma, least blood loss, and short hospital stay. Now the most dangerous phrase, this is what I always feel, people still feel like Tony was sitting with me in the morning at the breakfast table, He said, sir, people in Indonesia, the seniors, are not able to accept laser in Indonesia. Same problem I faced, but I had a good person who happened to pick me, and that was Dr. Kushan Mittal when he started the course in IMAST. That was a turning point of lasers in India way back in 2018. So I personally feel the most dangerous phrase is, we have always done it this way. Thank you.
Permasalahan ini dia belum masuk di ESGP dong. Belum ada di
Thank you, Dr.
guidelines.
Paul.
Itu.
And, I can say that